So good morning, everyone. I see we have about 500 students, attendees in right now. So we'll get started with some housekeeping and then we'll move on into our presentations for this morning. Um, I know I've been bumping into more and more of you students over the last 2-3 weeks as the campus has been almost fully reopened for all of us to be involved in it, participating with each other. So it's been great to see many of you in OMM lab and DPR lab and all around the campus. So that's definitely a positive experience. Hopefully we can keep that going. So over this weekend, of course, with President's Day weekend, uh, just a little housekeeping, just make sure you stay professional, keep yourself safe, keep the people around you safe, but definitely take a break and enjoy the weekend as well. It's supposed to be some nice weather later this weekend in the New York area. So with that being said, this morning we're going to be doing our clinical practice reflection. And at around 12 o'clock Eastern time, I'll be sending out the link that you can send your reflective statement. What I'd ask you to do is try to do your reflective statement this afternoon while the thoughts that you're going to be exposed to are fresh in your mind and you can get right into it. And just share your impressions and your thoughts. And like always, we take those reflective statements that you share with me, I de-identify them, and then I share it with the panelists so that they can see the impact that they had on you. And sometimes that helps the panelists know which direction to go in the future to inspire more people to do the amazing things that they're doing. The other thing we're going to do is after this panel discussion is we'll be going into our careers in medicine professional identity development session with Ms. Deb Heinemann. And so that one is mandatory for second year students, but first year students, I just talked to Deb and she said that she thinks it could be just as helpful for you as in first year as it is for a second year student. So feel free to stay on board. With that being said, we have an amazing panel here today. And today is part of a two-part series of wrapping up our clinical practice reflection where we're doing a local perspective. So this year, you've noticed that our clinical practice reflections are really based on an individual patient or an individual situation that either affects you or people in the community. Today and during our April session, we're going to branch out and look more at a global perspective. And for that reason, Dr. Lillian Niwagaba, our Center for Global Health's director, on board to kind of inspire us and kind of branch out. And what I always say is the brilliant part about living in New York is that New York, practicing in the New York metropolitan area is global health. You can't get beyond the fact that each day you're going to be interacting with people that are local and global. In fact, the other day I was talking to my other half, and we actually thought it was interesting that we went through 2 full days where the only people we interacted with were not born in the United States, and that we had not met another person other than each other that were born in the US. So, with that perspective, it makes you think, what is the considerations or concerns in Long Island are going to be the concerns that affect people worldwide, and what affects people worldwide can be here. Today, we're going to look at addictive diseases or addiction and the implications in the world. And so, like what I implied with my email with you all this morning as a reminder for this session is we've been under this global pandemic of COVID. And addiction medicine is near and dear to my heart because that was where I started my clinical practice. During my residency, we had a methadone maintenance center and a detox unit in the hospital. And we were one of 2 units in Nassau County at the time that was providing those services. And so as a family medicine resident, I was expected to figure out and learn this perspective. And, what I thought was really brilliant was when you would see people have their success stories and you'd see them out in the community and they would be changed, they would come in and be really sick and ill in the emergency room. And then we would get them physically better. But if we didn't do anything beyond that and we just sent them home, the disease just kept progressing and we kept seeing the person come back. And it would wear on the faculty in the hospital. And sometimes it made us have maladaptive behaviors towards these patients. And the biggest thing I ever found was when I found that I could treat these patients in outpatient settings where I could offer them something other than an in-hospital setting. It was really brilliant because I could see people getting jobs, becoming productive again, getting their families back, or finding what made them happy. You know, maybe sometimes it's not necessarily what I think makes someone happy, but what makes them happy and productive. And so it really kind of changed the way that I see people and the way that I was treating patients that have challenges with addiction. And the challenge that I saw with the pandemic is we kind of forgot that there's been this epidemic of addiction on Long Island, across the country, and across throughout the whole globe. And so when Dr. Niwagaba came and said, you know, like, I have these brilliant speakers, these brilliant researchers, I said, we got to get these people in front of our students because we have to bring this back to the perspective, because as this global pandemic of COVID starts becoming more controllable, we got to get back to taking care of the diseases that we were forgetting. And so with that, I'm going to turn this over to Dr. Niwagaba, and then I'll join you guys at the end for the Q&A and help moderate that component.
Thank you, Arden. Again, I just want to emphasize the Center for Global Health has several programs that you can be involved in, and the Certificate in Global Health is one of them. We also run the Masters in Public Health and ethical challenges in global health, and a whole bunch more. So it's your resource here in the com. Please engage with us. Thank you. Now let me turn it over to Miriam Chickering to go ahead and introduce her team and do the next Gen U presentation. Thank you.
Thank you so much. It's wonderful to be here with all of you today. My name is Miriam Chickering. I'm the Chief Executive Officer of the Ulrich and Ruth Frank Foundation for International Health. And one of our main projects is the Annenberg Physician Training Program, Abstinence-Based Recovery from Addictive Disease. And that's the team that's here today to talk to you about addiction. So I'm going to share a little bit about our programming, but before I get started, I'd like you to think about two questions. The first question is, how many of you have been thinking, I'm planning to treat patients with addictions? How many of you have been thinking, as a physician, I plan to treat patients with addictions? And then the second question that I'd like you to think about is, how many of you know someone with an addiction? Do you know someone that has an addiction? And my guess is that many of you here haven't really thought, I'm definitely going to treat patients with addiction. But I can tell you that based on readily available statistics, that all of you will treat patients with addiction, just like probably all of you know someone who's had an addiction. And so because addiction is so relevant to all of the healthcare system, it affects every body system. And no matter where we are in that system, we will treat patients with addiction. We're here to bring you information about how you can do so and how you can do so successfully. So with that, I'm going to share my screen and introduce you to some of our programming. NextGenU.org is a program of the Frank Foundation, and we have learners in every country through 300 universities. One of our programs is Humanitarian U. We've trained 33,000 humanitarians. We are also building STEM curriculum for primary school in 3 countries and plan to take this global. At Public Health U, we're training about 140 physicians and other healthcare workers each semester, and our students are from over 50 countries. The APTP, or the Annenberg Physician Training Program, is one of the programs at the Frank Foundation, and we have courses that are totally free and completely accessible for anyone to take. And we have many cohorts of physicians and medical students taking these from through 77 US med schools, but also globally. We offer a concentration in substance use disorders and mental health with the NPH program. And you can check out the courses that are available in that concentration. And then because every physician will treat patients with addiction, we have threaded addiction content through all of our courses at Public Health U, at NextGen U, and professional development, public health, and clinical medicine. All of our programming is driven by research that's occurred over the last nearly 2 decades. And this research falls into one of these categories. It's been really exciting to track the genesis of the research, the change of the program over time in response to that research, and now how that research is being used to influence policy. The research is in several categories: online education and addiction, medical students and addiction, residents and addiction, physicians and addiction, international health workers and addiction, and health policy and the environment and addiction. And Dr. Erica Frank will be with you at the end of today's session and talk to you more about the research related to addiction. Thank you so much for your time. If you'd like to contact me, you can reach me at mchickering@nextgenu.org. Thank you. And then next up, we will have Dr. Kalina. She is an MD, MPH, medical doctor in France, and a nextgenu.org researcher. Her research focuses on substance use and misuse among adolescents in France. And she's also interested in investigating child and adolescent health, global health, and environmental health. She's a volunteer regional leader at the International Working Group for Health System Strengthening, and she's published in peer-reviewed journals, participated in conferences, and won awards for position on infectious diseases and strengthening health systems. We're so lucky to have her as part of the APTP team. Thank you. Over to you.
Thank you, Miriam. Let me share my screen. All right, so good morning, everyone. I'm Dr. Magali Colonna. I will start this presentation by giving a quick overview of the global burden of addiction in the world, and then I'll explain why adolescents are particularly vulnerable to addiction. So first, let's define what addiction is. It's important to make a difference between addiction and dependence. Dependence refers to the physical symptoms a person can experiment when they stop using a drug. On the other hand, addiction refers to a change in behavior due to continued or uncontrolled substance use. It's a disease defined in the DSM-5 classification by 11 diagnosis criteria. And there are 10 major classes of drugs that can lead to addiction, and this includes alcohol, tobacco, cannabis, and opioids. Another important point to remember is that tackling addiction is part of the Sustainable Development Goals. SDGs are 17 goals defined by the United Nations to be achieved by 2030. SDG 3 refers to good health and well-being. It has a specific target relating to addiction. It's SDG 3.5, strengthen the prevention and treatment of substance abuse, including narcotic drug abuse and harmful use of alcohol. Let's now have a look at the global burden of disease caused by addiction. In 2019, 20% of the population in the world were either daily or occasional smokers. And in the US, it's 5% of high school students who are occasional or daily smokers. In addition, 107 million people in the world suffered from alcohol use disorders. And in the US, 5% of high school students regularly engaged in binge drinking. Finally, 1% of the population in the world suffer from a drug use disorder. Alcohol and drug use are responsible for about 11 million deaths per year in the world and for around 1.5% of DALYs. Some of you may have already heard about DALYs. It's an indicator of the burden of disease that takes into consideration both the mortality caused by a disease, and also the disability. In the US, alcohol use and drug use are responsible for almost 7% of the deaths. That's around 4 times the worldwide figure, meaning that addiction is a major public health issue in the United States. Let's now focus on adolescents' substance use. Adolescents are particularly vulnerable to addiction. First, they are more likely to engage in risk-taking behavior, and they often experiment with tobacco, alcohol, cannabis, or other drugs. In addition, they often engage in reward-seeking behaviors. And because of this, for peer acceptance, they are vulnerable to peer influence, and they can adopt a specific behavior just to be included in peer networks or in activities with their peers. Besides, research shows that they engage in risky behaviors more often when they are with peers than where they are alone. There's also been a lot of evidence showing that the tobacco and alcohol industries try to make their products more appealing to adolescents in order to increase their desire to use them. To give a few examples, they use strategies like product placement in movies, advertising at events, or paying influencers to share pictures with their products on social media. They've also tried to design products targeting youth directly, such as flavored cigarettes, flavored e-cigarettes, or colorful packaging. So we've seen that adolescents have an increased risk of experimenting with various substances, but why does this matter in terms of public health? Scientific evidence shows that many adults who suffer from addiction started using substances when they were adolescents. For example, in the United States, it is estimated that around 1 in 4 Americans who began using substances before 18 years old developed a substance use disorder later in life. It has also been proven that earlier initiation of smoking or alcohol use is associated with a greater risk of sustained and problematic use later in life. Given adolescents' vulnerability toward addiction, it is extremely important to implement substance use initiation prevention strategies targeting adolescents directly. There is indeed strong scientific evidence for the efficacy of substance use prevention programs and policies in adolescent populations. There are different types of prevention strategies. I'm going to give a few examples in the next slides. But what is very important to keep in mind is that prevention programs or policies should be adapted to the target population, their local culture, and specific needs. So on this slide, you can see a diagram showing the determinants of health. An individual's health is determined by individual factors, such as genetics or lifestyle factors, but it's also determined by the social environment and the global environment. Let's first have a look at prevention strategies targeting the socioeconomic and environmental conditions. These are mostly strategies implemented by governments or international organizations. Governments can implement industry regulations, such as banning flavored cigarettes or imposing plain packaging. They can also implement health policies, such as smoke-free schools, banning smoking in public places, setting a minimum age for purchasing tobacco or alcohol, or even regulating advertising for tobacco and alcohol. But prevention strategies can also target the social and individual lifestyle factors. These strategies include health education and behavior change interventions. These can be media campaigns or programs held at school, within the community, or within families. Prevention strategies can target the individual, the adolescent himself, but they can also include their peers or their family. As I mentioned before, peer influence is a major determinant of substance use in adolescent populations, but adolescents are also influenced by their parents and siblings. This is why including peers or family members in prevention programs has proven effective. Regarding the program's content, the program can focus on information sharing, behavior change, or skills development, such as coping skills, problem-solving skills, or emotional skills. So far I mentioned prevention programs and policies, but healthcare professionals do have a role to play in substance use prevention in adolescent populations. This can be done by screening adolescents during routine checkups. First, it will help raise awareness on the risk associated with substance use, but it will also allow for early intervention when necessary. There are several brief substance use screening tools that can be used in your daily practice with adolescents, such as the screening to brief intervention tool. This slide is just to illustrate how quick and easy it is to use the screening to brief intervention tool in your daily medical practice. There are basically 5 short questions with 4 possible answers for each question. The questions ask about substance use in the past year for tobacco, alcohol, cannabis, misuse of prescription drugs, illegal drugs, inhalants, and synthetic drugs. And for each question, you will have to choose between never, once or twice, monthly, or weekly or more. Once you answer the 7 questions, you will get a detailed report with an overall level of risk for your patient, as well as suggested clinical actions for each drug identified by the screening tool. And you will also have specific guidance for the physician. Thank you for your attention, and you can contact me if you have any questions on prevention strategies in adolescent populations. I'm now going to introduce a speaker, Dr. Schlaff, who is a medical doctor, and he is a director of the Public Health Program and professor in the Department of Public Health and Community Medicine at the Tufts University School of Medicine in Boston. Dr. Schlaff received a BA in history from Yale University, a medical degree from Columbia College of Physicians and Surgeons, and an MPH from the Harvard School of Public Health. He trained in internal medicine at Boston City Hospital and in preventive medicine at Carnegie Hospital in Boston, and is board certified in both specialties. After several decades as a primary care physician, he now does his clinical work in addiction medicine, and he worked as a medical doctor and director of quality improvement in several community health center networks, and he has directed several community health initiatives in Boston and New York. He is a past president of the Association for Prevention, Teaching and Research and winner of the 2017 Duncan Clark Award. His current work focuses on teaching about structural racism as a social determinant of health for both public health and healthcare professional students. Thank you, Dr. Schlaff.
Well, thank you for that introduction. Let me share my screen, if I can. So the part of the introduction that might be most important for this group that Dr. Kalina does not know is I'm a New Yorker. So even though I'm living in Boston and working in Boston these days, I kind of wish I was live with you rather than doing this on the internet. I'm hoping people can now see my slide. And I'm going to try and focus on treatment. I have very little time, but I'm going to start from a public health perspective in a way that I hope and think complements what Dr. Kalina did. I want to give you a little bit about US epidemiology, and then talk about the way that treatment fits into a public health response, and then emphasize how a public health lens might really help you think about treatment, particularly how to overcome stigma, which is such a big part of the problem of substance abuse, certainly in the United States. So this is a different model of public health. Dr. Kalina showed you sort of what's called the social ecological model, which gets us to think about public health at different levels of social organization. This allows us to think about what are the activities of public health. And writ large, it's to assess problems, to develop policies and programs to address those problems, and then make sure that those programs are in place. And a critical part of that assurance function is to link people to proper care. So when we think about what key public health activities include, it's that epidemiology and surveillance, then a root cause analysis. Like, why is substance use so much of a bigger problem in the US and worldwide, as well as being a big global problem? Then public health moves into policies, prevention, promotion, community protection, And this involves both organized community action through government or through other ways, programs and advocacy, and then also quality healthcare, access to it for everybody who needs it. So some quick statistics on the US to fit in. You learned a little bit about New York State, a little bit about global. What's important on this slide is, first of all, that in the US, a lot of people, the majority of people, use drugs at some point or another. That doesn't necessarily mean they have a substance use disorder. What's also shown on this slide is that a lot of the substance use, as well as substance abuse in this country, is tobacco and alcohol. So when we move from alcohol and tobacco to illicit substances, we do see that the numbers drop a little bit. So the past month use of illicit substances is about 12%. Similarly, when we move from thinking about use to disorders, we see that alcohol use disorders are quite significant, over 5% of the population. Illicit drug use disorders are less prevalent, but still significant. 3% of the US population is thought to have an illicit drug use disorder. I'm going to focus a lot on opiates, where it's about 0.75%. We are so much concerned with opiate use because even though by definition, if you have a substance use disorder, you are doing harm to yourself or to others through your limited ability to participate in your social and personal functions. Opiate use, as you've seen in some of the slides shown earlier, is the one that is most lethal, certainly most lethal quickly. Probably overall more people die of alcohol use and tobacco use than opiate use disorders. But opiate use disorder is the one that can kill you the day you start using or the first day that you relapse. The other important thing on this slide is just to understand that a significant number of people with substance use disorders have co-occurring mental health disorders. So when we treat people, it's important that we think about how to treat both simultaneously. I think you already saw some of this data for this huge uptick over the last 20 years in overdose deaths. Again, this was fueled in part by prescription use, practices by physicians to grossly overprescribe these drugs. We did learn a little bit, although one of the concerns is that the second wave of an increase in deaths that we saw pre-pandemic, but in the teens, is that as we got more careful about the prescribing of opiates as prescription drugs, many people were just abruptly cut off from their supply of prescription drugs without being referred for treatment. And therefore, they were more likely to go to street drugs, including purchasing prescription drugs on the street or using illicit drugs like heroin and fentanyl. And this might be responsible for some of the rise that we saw pre-pandemic. And now with the pandemic, we are seeing this, once again, a huge spike. The current year, the 2020 was even higher, 2021 is even higher than 2020. It's important to think about risk factors. This does not necessarily imply cause, but what are the things that we know are associated with substance abuse? So if you are a clinician, you want to think about these: family history, childhood adverse events, and or poverty. Clearly, children who are poor are much more likely to be exposed to adverse events in childhood. Mental illness, as I mentioned before. And as Dr. Kalina mentioned, social context is important in terms of risk for access to drugs at an early age in adolescence, because early use puts you at risk for developing a substance use disorder. And just moving from thinking about these as risk factors to say, well, what's causal in this risk factor framework? And I say hypothesize, there's some proof in here, but it's best not to quickly oversimplify and assume cause where it's not fully proven. But genetics clearly plays a role, trauma plays a role, the environmental exposures in early life. Talked already a little bit about prescription drug use. And again, the role of both corporate and medical misconduct, even malpractice, and even illegal activity in fueling that prescription drug overuse. And finally, we won't have time to talk about this, but criminalization of drugs itself, perhaps actually paradoxically, leads to more misuse, abuse disorders, and again, limits to treatment, which then prevents us from reducing the burden of disease. So again, public health responses writ large start with, we probably the single most important thing we could do to reduce substance abuse use in this country is reduce poverty. As physicians, that's not going to be in your wheelhouse, but it's important to know the limits of our tools and what else has to be done. Changes in cultural norms. Reduced access to drugs is the central way that we have used policy to dramatically reduce tobacco use in the United States. And we can apply reducing access to drugs for other drugs as well. Again, criminalization is not the most effective way to reduce access to drugs. Raising the price, making it more difficult, and certainly making it illegal for people under the age of 21 are important. We'll talk a minute about harm reduction. I think Dr. Kalina gave you an introduction to clinical prevention. And then increased access to treatment. Treatment should be available on demand. So with a public health lens, what does this tell us about treatment? You've already heard that it is a disease. It's really critically important to hold on to that disease model. There was an op-ed page in the New York Times just 2 or 3 weeks ago challenging the notion of addiction as a disease. And what I would say to all of you, again, would love to have an hour to talk with you about this, is that some of these attacks on the notion of addiction of disease are actually rooted in stigma, right? I mean, people will say, well, it's not a disease because people have agency and there's a personal choice involved. Well, there's also a personal choice as to whether you wear a mask or get a vaccine that changes your risk of COVID, right? Or people will say, well, this is so socially determined, but every disease is socially determined. So I think addiction fits very well into a disease model, and it actually puts us in a position to give people the treatment that they need. It's really important to understand that we can treat this disease with a range of things. I prescribe, the drug I most commonly prescribe is buprenorphine, but methadone, which is a full agonist opiate, which can also lead to overdose, misuse, deaths, but it is also useful in treatment as a harm reduction strategy. And understanding the disease, the pathophysiology, can help you understand why, even though you perhaps might prefer buprenorphine over methadone, it's got to be part of our armamentarium. I already mentioned no barriers to access. Treatment works. And here I want to introduce you very quickly to a public health concept that I call numerator denominator confusion. As I noted, there's a lot of stigma in our society about drug use, and physicians are not immune from this feeling of stigma. And in fact, the way many of us practice makes that stigma understandable. What am I talking about? If you are an emergency room provider, you are going to see, as Miriam Chickering mentioned, people with substance abuse. You're going to be treating them day in, day out, right? What you are going to be seeing in the emergency room more often than not is treatment and prevention failures. People are in the emergency rooms because of their substance abuse or because of a medical condition or an injury as a result of their substance abuse. They may even be in there to scam you for prescription drugs. So it's very easy to get cynical and to think, what I mean by numerator denominator is that that emergency room provider begins to think that the world that they see day in and day out in the emergency room is the denominator, is what substance abuse is writ large. But I do outpatient practice treating people in substance abuse. The majority of my patients have been people who have been sober for 3 years or longer. They have gotten their life back. They no longer manipulate. Sometimes they relapse. Sometimes they lie to me. When they lie to me, I call them on it and we move forward. We're in a therapeutic alliance together. They have made amends. They've made reparations to their family and friends. And the good person who might have been lost behind the disease of substance use now reemerges. Treatment works. And if you're seeing it from a limited numerator perspective that leads you to think in a stigmatizing way, be aware of that. Harm reduction is another public health way we have to think about treatment. I don't want people to die, right? If somebody relapses on their buprenorphine, they're less likely to die because the buprenorphine provides them some protection, right? So the issue is not judging them for the relapse. It's trying to make sure that they keep taking their buprenorphine no matter what, and then we work on relapse prevention. It needs to be trauma informed. Again, because of the trauma that might be causal in the pathway leading to substance abuse, because of the ongoing trauma that they may have in their lives because of substance abuse, we can't ignore those traumas if we're going to keep a relationship and keep treating people. And we also have to, again, address the social determinants of health. People need to get their lives back. They need family. They need a broader social network. They probably will do better once they can get a job. And I've seen treatment programs that sort of insist people not work, and that can sometimes be appropriate early on when they need to focus purely on recovery. But you don't want to hold people back with your treatment in a way that doesn't let them to go on with their lives. So medically assisted therapy, using an opiate to treat opiate use disorder, we have to understand this as harm reduction. You will hear people say, I don't want it because it's just replacing one addiction with another. Again, Dr. Kalina's made the point, it's not addiction, it's dependence. I tell my patients who tell me that, who worry that they're still addicted, I say, if you're on buprenorphine, taking it appropriately, and you've got your life back, and you're filling all your social and personal roles and goals, then you're not addicted because there's no harm being done. And then I tell them, I am heavily dependent on coffee. If I don't have my morning coffee, I get a headache. But what's the moral failing in my having my cup of coffee? I would say none, and there is no moral failing in people taking a harm reduction strategy to treat their disease. We have to be destigmatizing. I have seen substance abuse programs that if somebody relapses, they kick people out of the program. I mean, that wouldn't be like telling a diabetic, you ate a hot fudge sundae, I'm not going to give you your insulin anymore. We have to bring people more into treatment if the treatment isn't working, not kick them out of it. We have big problems with access, big problems with stigmatization and barriers to care. So I hope you're part of those solutions to that. I know our question and answer will be coming after we're all done. So it's now my pleasure to introduce you to Dr. Bianco, the physician. He's chair of the World Heart Federation. He's an expert in tobacco prevention and control and cessation, has been very involved in Latin America on efforts to do that. Former regional coordinator for the Americas Framework Convention Alliance, and a former technical director of the MOH Center for International Cooperation for Tobacco. So again, I will stop sharing and turn this over to Dr. Bianco.
Thank you, Chair. It is a pleasure and an honor for me to participate in this important event as part of the NextGenu team. In this brief presentation, I will try to share with you some concepts and lessons learned from my experience in the WHO Framework Convention on Tobacco Control, an international public health treaty in which I have been involved since its inception in 2000. This treaty is being looked at today as a model to follow in addressing other global health problems. I will make a brief introduction to the tobacco problem and the global tobacco epidemic, and then address the treaty itself, its main elements, its structure, its impact, and with some general comments. According to the WHO, tobacco is the main worldwide absolutely preventable cause of death, causing 8 million deaths annually. Tobacco products are unique products because they kill more than half of their chronic users. Not only do they sicken and kill those who consume, but also those who live, work, or study with the person who smokes, to secondhand smoke. There is no minimum safe level, neither consumption or exposure, not exposure. Most people who smoke started and got hooked when they are teenagers. Another important factor of this product is their highly addictive nature. Most regular smokers become dependent or addicted to tobacco due to nicotine. Nicotine reaches the brain quickly, in about 10 seconds, and that speed of arrival makes it very addictive, as much or more than cocaine or heroin. The faster a psychoactive drug reaches the brain, the greater the addictivity potential. Three types of factors are involved in tobacco dependence. Biological factor related to the aforementioned nicotine effects, psychological and behavioral factors, including Pavlovian and also operant conditioning, and social factors. Society gives value to such consumption. In the case of tobacco, it is associated with pleasure, company, relaxation, and other things. The sum of these factors causes a structural and functional modification at the brain, and they are the basis of the neuroadaptation that underlies nicotine dependence. Physicians have played and still play an important role in the tobacco epidemic. Doctors were among the first social groups to smoke and consolidate their smoking habits. And even some doctors, influenced by tobacco industry, promoted tobacco products and defended light cigarettes as healthy products. But medical institutions such as the UK Royal College of Physicians in 1962 and the Surgeon General, US Surgeon General in 1964 were also the first to become aware of and alert the population to the serious harm associated with tobacco use. Although physicians and other health professionals continue to play an important role in tobacco control, many physicians continue to fail to manage their smoking patient because they do not understand the chronic nature of tobacco dependence. Now let's talk a little about the global tobacco epidemic. Around 1.2 billion people smoke tobacco worldwide. 80% of them live in developing countries, showing that the burden of the epidemic have shifted towards these countries since there have fewer strict regulations. This global epidemic has severe health, economic, and environmental costs, and therefore social costs for almost all countries. In the 20th century, some 100 million people died from tobacco, and for the 21st century, it is projected that 1,000 million tobacco deaths. The tobacco economic damage is estimated at $1.4 trillion per year, which is equivalent to 1.8 of the world GDP and 5.7 of the global health spending. I also want to highlight another very important element of this epidemic. It is the fact that it has been industrially produced. A fact that confirms this is that the disease most strongly related to tobacco, lung cancer, at the beginning of the 20th century, it was a rarity in hospital. But in the middle of that century, and following the exponential growth of smoking, this cancer became the main cause of death in men. Industrialization, the development of advertising, and later globalization promoted and strengthened the activity of the tobacco companies. In addition, the tobacco industry hid and manipulated information about the harmful and addictive nature of this product with the aim of increasing his profit. The tobacco industry especially multinationals, has been and continue to be the main obstacle to tobacco control worldwide. The main interest behind their action is profit. Another important factor, and not a minor one, is the economic power of the tobacco industry. In the early 2000s, the annual income of the main multinational tobacco company, PMI, exceeded the annual GDP of several Latin American countries combined. But PMI is not the only one. If we put if we put together all the Western multinational companies and add the China Tobacco Company, which is already another multinational, we can see that the power of this industry is enormous. This economic power translates into a huge influence worldwide. Given these characteristics, the growing evolution of the tobacco epidemic was not going to stop by chance or accident. Deliberate and coordinated international action was needed to do so. A global problem required a global response. And this response, which I'm going to mention, the Fhcdc, did not happen by accident, but was the result of a few intelligent and committed people, of which I will highlight two. Professor Ruth Rommers, a US lawyer who was the promoter of the idea of using the constitutional right of the WHO, provided for in Article 19, which allowed WHO to convene a world treaty to address global public health menaces. And the other one, Dr. Gro Harlem Brundtland, who in the late 1990s was the Director General of the WHO. Both managed to overcome bureaucratic obstacles and convince the World Health Assembly to begin the process of the Framework Convention on Tobacco Control. But what a Framework Convention is, when that is applied, and how does it work? It is an international legal instrument which has been used in several human and environmental rights treaties. And for the first time, it was used in a health issue. It arises when there is a lack of political consensus, or what are the most effective measures to address a problem, when scientific knowledge about it is still developing, and when the problem is modified. Once the process has started, it makes it easier for the parties to first reach a cognitive consensus, what the problem is, its characteristics, and the technical solution, and then give way to a normative consensus on what the appropriate legal responses are. Let us now focus on the treaty. As I said, it is the first global treaty negotiated under WHO auspices. Records the determination of the party to give priority to their right to protect public health. It is an evidence-based treaty that reaffirms the right of all the people to the highest standard of health. It is an international legally binding multilateral instrument and a new approach in international cooperation on health. It was possible because after a tough political negotiation that took 3 years, and it was really very hard to get. In relation to the process of adoption of the convention, this had the first meeting of the intergovernmental negotiating body in 2000. It ended in February 2003 and was unanimously approved by the World Health Assembly in May of that year. On February 27, 2005, it got into force internationally. As of today, there are 183 parties to the convention, and it covers 90% of the world population. Unfortunately, the United States is not part of it, as you can see in the figure. The objectives of this convention is to protect present and future generations from the devastating health, social, environmental, and economic consequences of tobacco consumption and exposure to tobacco smoke by providing a framework for tobacco control measures in order to reduce the prevalence of tobacco use and exposure to tobacco smoke. States, parties under this convention are obligated to develop comprehensive multi-sectorial national tobacco control policies, establish and finance a national coordinating mechanism, adopt and implement effective national tobacco control legislation, protect these efforts from the commercial interests of the tobacco industry, as well as to cooperate with other parties and international institutions. Let's address now the core Fhcdc provisions. Within them, we have two groups: measures to reduce demand and measures to reduce supplies. Within the first, we have measures related to tobacco prices and taxes, which are the most effective measure to reduce and prevent smoking. And the measures that are not related to prices, they are the protection from tobacco smoke exposure, regulation of content and emission of tobacco products, regulation of tobacco product disclosure, regulation of the packaging and labeling of tobacco products, measures related to education, training, and public awareness, and a total ban on tobacco advertising, promotion, and sponsorship, and as well as measures related to tobacco dependence and cessation. In relation to supply reduction measures, the convention has included measures to tackle illicit trade on tobacco products, prohibitions of sales to and by minors, and considers the provision of economically viable alternative activities for tobacco growers in some low-income countries. I will comment briefly on the structure and on the functioning of the convention. The main governance body is the Conference of the Party, the COP, which meets every 2 years and discusses the situation of the epidemic, the progress and difficulties in implementation, and takes decisions to help the parties. To support the COP, there is a convention secretariat that is in charge of the administrative and logistical processes of the treaty. The secretariat works with a bureau integrated by representatives from all the regions, which is in charge of the management advice in the periods between sessions of the COPs. In addition to the parties, there are observers who have voice but not vote. Within this, we find intergovernmental organization and non-governmental organization. I want to emphasize that the Fhcdc Code also approved the development of a protocol on illicit trade of tobacco products, which is a parallel international treaty, and only states that are part of the Fhcdc can be members. And this new treaty is already in force and has 64 parties members. Let's talk a little bit now whether or not the Fhcdc has had an impact. It is a young treaty. It has been in existence for about 15 years. But evaluation made in this regard show that the treaty has had an impact. Smoking worldwide has decreased in percentage, but not so much in absolute numbers, given the exponential growth of the world population. The greatest impact is achieved when the measures are applied together within a short period of time. The countries that have implemented most of the measures have had the greatest impact on smoking reduction. In the image, you can see some examples. The big problem is that the application of the set of measures is uneven, both between regions and between type of measures. To finish, I want to highlight two aspects that also make the Fhcdc unique. The first is that it represents a paradigm shift in the regulation of addictive substances, both by prioritizing the public health approach and by including measures to reduce supply and reduce demand. Second, it is related to the regulation of tobacco industry. This industry was excluded by the negotiation and cannot participate in any way in the COP session, nor in the development and implementation of tobacco control policy at national level. Because as a principle, it is considered that there is a fundamental and irreconcilable conflict of interest between the tobacco industry and public health policy. There is a specific article, Article 5.3, which has some guidelines that orient the state on how they should interact with the tobacco industry. In conclusion, the Fhcdc is the first public health treaty under WHO auspices. It was ratified by the whole of government. It means that all the government branches have an equal obligation, because the treaty implies a comprehensive approach and goes beyond public health, goes beyond the Ministry of Health, the Secretary of Health. It implied a change in the intervention model and the taking of urgent actions on tobacco control. And most importantly, it is working. Although not perfect, the Fhcdc is a model to follow in addressing other serious global health problems. Medical students could and should play an important role in the fight against this epidemic. I hope many of you can join the international tobacco control movement and also join next gen new tobacco control and tobacco cessation courses. Thank you.
Wonderful. So I think it's my turn now to share my slides with you and my thoughts about this global perspective on addiction medicine. So this is me at my TED-Med talk. I'm a prof at UBC in Vancouver. I am the founder and inventor of nextgenu.org as well, which you've been hearing about, and the founder of the Healthy Doc, Healthy Patient Initiative. And that's a bit of what I'm going to be talking to you about for the next few minutes. I'm also the past president of Physicians for Social Responsibility and the former co-editor-in-chief of Preventive Medicine. So the piece that I'm going to be bringing you today hopefully will bring all of these components together, talking about your personal health, going all the way up to a global perspective. And I'm going to briefly talk about the evidence-based links that I've accumulated in a few decades of doing research on physician and medical student health in the US and globally, particularly around addiction medicine. I want you to be able to, by the end of this, refute some of the toxic myths about our mental and physical health, especially our addiction medicine practices, and to think about how to improve our personal health and that of patients nationally and globally. So the foundational questions that we answered first was, what's happening now? What are contemporary physicians' mortality rates? And you can see here, of course, the same tragic bifurcation that we see in so many places, including in the United States, of a profound difference stratified by ethnicity for professionals of all types. But you can see in particular that both for white male and for Black male physicians, that physicians tend to live for longer than do other professionals, and certainly for longer than do folks in the general population. So the next question, of course, is why are our mortality rates lower than those of other professionals? Pause and think for a second about that. Why we might have even lower mortality rates than other professionals, because it's not just about socioeconomic status, right? It's about likely, of course, our health knowledge. And just to highlight in particular two addiction medicine related components, this is comparing women docs with our national study with high socioeconomic status women in the general population from the CDC's behavioral risk factor surveillance system and other women in the general population, finding that women docs are more likely to have never smoked, much less likely to be current smokers, and those who smoke less and have quit for longer. And this is true also for male docs. In terms of alcohol, less likely to abstain from alcohol than folks in the general population, but less likely with self-report to binge. And we see this in other populations too, and in other practices. So Canadian docs, same thing, excellent health, low rates of overweight and obesity, good fruit and veggie consumption, though opportunities for improvement, and particularly around addiction-related practices, docs tend to do better than do the general population. So again, producing lower mortality rates. So does it make a difference to our patients? Of course, we want to make sure that we all help each other stay healthy. And Dr. Blasey, I think, was saying that combination in his enjoining y'all to have a professional and fun weekend. But what difference does it really make to our patients? And we found that for every practice at which we looked with these 4,500 US women docs, that if a physician had healthier practices themselves, that they were more likely to counsel their patients on related issues. So true for diet, for exercise, for alcohol and smoking, for flu shots and breast self-exam, sunscreen use, and back when we thought hormone replacement therapy was a useful thing generally for HRT, and even for screening as well, for cholesterol testing, blood stool testing, and skin exams. If a doc does it themselves, they're more likely to talk to their patients about it. And this was true, in fact, for all 14 practices at which we looked, that if you, other than being a primary care doc as an important predictor of counseling patients, if you practice a related personal habit yourself, you're more likely for all 14 of these practices to talk to your patients about that practice as well. So the final piece of data on this is looking at the association with electronic medical records between these practices. We did this with 1,500 docs and 1.9 million patients, and found that for every one of the practices at which we looked, that if the doc was eligible and had the procedure done in the recommended way, the preventive intervention, that their patients were significantly more likely to receive that same intervention themselves for all of these preventive practices demonstrated here with electronic medical records. And of course, there are other components to it. Patients care about this. The role modeling piece matters. This is a small study that I did when I started at Emory, and showing that when I spent an extra 30 seconds talking about a few healthy practices of my own, in addition to a standard 2-minute spiel on eat healthily and exercise, that extra 30 seconds, unsurprisingly, the patients thought that I was healthier, but they found me more believable, significantly more motivating, and specifically both on diet and exercise, significantly more believable and motivating. We know that counseling makes a difference in patient outcomes. We know that these 4 factors significantly influence mortality rates, 40% of US mortality attributable to that. And we know that despite that, that we and our colleagues are not doing the best job. So this is a summary of those pieces. And I want to just quickly close with the intervention that we did with US med students to improve patient practices and through improving personal health. So we did this study on the class of 2003 at 17 US med schools. We found that US med students' practices are quite positive overall, especially around things like exercise and tobacco, and surprisingly not horrible on sleep, and a strong healthy worker effect. But there were some obvious places for improvement on fruit and veggie consumption, on binging, and on screening practices. We did find that US med school students had the same relationship between personal and clinical practices, with drinkers thinking it's less likely for it to be relevant, going back to Miriam's initial point about counseling patients, and even a stronger effect if one was a binge drinker. And you can see that really for all of these practices, alcohol, tobacco, practicing safe sex, that if you had healthier practices yourself, you were more likely to think it relevant. If you were a medical student, to talk to your patients about those issues and to actually counsel them on those issues if you had healthier personal practices yourself. And we found that this was true also in medical students in Colombia for all 4 of these practices as well: diet, exercise, tobacco, and alcohol. And indeed, we found that our healthy doc, healthy patient study hypotheses were confirmed. The medical students were generally healthy, though some rooms for improvement. And then when medical schools encouraged y'all to be healthy, that it made it more likely that we would talk to our patients about disease prevention and think it relevant to do so. And that our personal health practices are correlated with how often we counsel and how relevant we think it is. So our health as docs and med students is inherently important, and it's important for our patients too. So I will stop there. That's where you can contact me. I think we have a few minutes left now for some questions and answers, moderated by you, Dr. Blasey. Dr. Blasey? Thanks.
Thank you. First, I just want to thank everyone, all of our speakers. Goodness, I really was enjoying listening to everything you were sharing. I know I'm going to take a couple practices home with me. So when I'm seeing patients on a Tuesday afternoon, I'm going to definitely have to engage a little bit and change up some of the ways that I'm seeing my patients. I also am happy you said that, Dr. Frank. So instead of me feeling like I'm bragging to my patients when I talk about my morning run or my evening swim, now I know I'm motivating them. So we have a program at NYTCOM called the Fhcdc program, where we encourage our students to do physical activity as well on Tuesday mornings, once it warms up a little bit. So all the student docs that are on this call that we're running with us in the fall, I don't think we're doing it this upcoming weekend, but I think the following weekend we're going to start. And what we do is we do a morning run before school starts and all that. And they do a whole bunch of other fit things. So engage with your patients. That's a good take home, because that helps get them to realize it's not just words we're saying, right? It's what our actions as physicians can actually change. So let's see here. I know that we had a couple questions, and there was one that came up for Dr. Schloff. And I think you answered it by a response, but I'm curious about this because this does come up with the idea of the supervised drug injection sites and the whole concept of the harm reduction. And I feel like sometimes it has sometimes that challenge of having a moralistic component to it as well. And so I was just curious, maybe if you could share a little bit, I know you wrote a really fantastic response, but if you could share a little bit more on the insights of like what you think is the effectiveness of the programs. And then, is that enough or should we do more?
That's a great question. Thanks. So I honestly don't know a whole lot about the data on the supervised injection sites. I actually think most of the good data is from Canada. So Dr. Frank might know more than I do if you want to jump in. As I understand it, again, these are very hard to set up legally because you're basically saying that we're going to put people who are supervising injections, observing illegal behavior, and then not stopping that illegal behavior. So it needs a lot of support from local politicians. In the US, at least, politicians have been very, not very eager to step into that space. And so the programs tend to be small, pilot. As I understand them, though, where there has been enough to look at numbers, there's not a big but a small benefit. What I do think is clear with almost every harm reduction strategy is that there is usually opposition based on this notion of moral hazard, that if we make drug use safer, more people will engage in it, and it will be therefore a net loss to society. And that has, as far as I know, never been shown for any harm reduction strategy. That every harm reduction strategy that we put forward does what it's intended to do, which is it reduces harm. People who are, there are a lot of people who are addicted and they are not ready for recovery yet. They haven't hit a place where the physiological and psychological boost they get from the misuse is worse to them than the harm that they're doing to themselves. Mm-hmm. So people are not going to be ready. But that said, I do not know anybody who is addicted who the reason that they stay addicted is because what they think they're doing is safe. Mm-hmm. When they're ready for treatment, they're ready for treatment, and whether they can do it safely or not. I mean, I have occasional patients who switch to cocaine and tell me, I won't go back to the opiates because I'm scared stiff of them. But honestly, I think that's the exception. People abuse drugs because they're trapped in a disease state, not because we're saying, if we let you die, you're more likely to come to treatment earlier. It just doesn't seem to work that way.
So I can indeed contribute a little bit more. Thank you, Tony. Locally, I encourage y'all to look at the work of Dr. Frederick Altice at Yale, who has done a lot of work with providing clean works around New Haven, working with prison populations as well around New Haven. And in Vancouver, the Naomi Project has provided a safe injection site for many years. Of course, huge political oppositions, but not only do they provide a safe injection site, they also provide clean, safe drugs. And there's been an enormous drop, not just in overdose deaths to zero, but an enormous drop in terms of the negative social implications of theft around in the neighborhoods around these treatment centers and other social implications. So if you want to learn more about that, that one again is called the Naomi, Naomi project in Vancouver.
Excellent. Now, I agree with what you brought up, which is really interesting, is that thought that there's always that concern, and it's worth reiterating because a lot of our students will go off and do community resource or community advocacy, where you go to a school or a hospital or like a community center or a church and share the knowledge that you have as a physician. And sometimes the fear is that if we educate people to safer ways of maybe not the clean work centers and safer sex or things like that, that would people think, well, now that they're educated, they'll do more risk. And it's good to hear like the idea, the evidence that shares that it doesn't make someone say, oh, because there's a center down the street, I'm going to start using drugs. It's like, and I think as a physician, it's important. Like when I was taking care of a lot of patients with buprenorphine, sometimes I think you shared this, Dr. Schlaff, how you'd rather see a patient relapse, like, if they relapse while they're on it, at least like the risk is reduced a little bit. And I remember when I first started prescribing it, the thought, and this was back in 2004, I think, or 2005, and it was pretty new. And the thought was, well, if they relapse on it, you got to kick them out of your practice. Like you have to have a zero, there's just no way, no area for error. And I remember that was a challenge to me. And I definitely pushed against that in my practice when I was in my own practice. And what I found is it kept them alive long enough so that they could, like when they were ready, they were still alive to be able to be taken care of, because a dead person with addiction doesn't get clean. They don't go into recovery or sobriety.
When I started in doing addiction work, it was more common than not that people would kick people out of medically assisted therapy for opiate use if they used marijuana.
Mm-hmm.
And it just floored me. So, because again, 90% of people who use marijuana are using it, not necessarily abusing it. Yes, teenagers, high risk of abuse, unclear whether it's a gateway drug. I personally don't think it is. I actually think many people who are opiate recovery, it actually can help with recovery. So the notion though of like kicking somebody out of life-saving treatment because of another thing that even if it is a problem is unlikely to kill them, and certainly is not going to kill them quickly, always floored me. If I could take a moment, I'll just push what you've said just a little bit further. I mean,
yes.
So buprenorphine is heavily regulated. I think some of that regulation is stigma-based. I think some of that regulation is because of how badly we burned ourselves with OxyContin, right? Mm-hmm. The powers that be don't want an opiate that's flooding the world out there. And that is a reasonable request. And it is our responsibility as clinicians to limit diversion. But I have trouble thinking about diversion as much of a problem as the DEA considers it to be around buprenorphine. Because if somebody on the street is purchasing illegal buprenorphine from somebody I've prescribed it to, the day they use it, they are safer than the day they used fentanyl.
Yep.
Now, the problem is, of course, I want them in treatment, not using it intermittently. I don't want them being a weekend opiate, fentanyl mm-hmm. user and a weekday buprenorphine user. But again, 5 days of the week using a safe drug is better than no days of the week using it. So again, I do take my responsibility to monitor, try and see that diversion isn't happening for my patients. But I think there's a way that the stigma and our being burned with OxyContin is perhaps causing us to overemphasize that concern.
Mm-hmm. I agree. There was an interesting question that came up, and it's an interesting one. Of the question was, as substance abuse professionals, what's your opinion on the popular TV show Euphoria and how it portrays the issue? And I know, Miriam, you added a link, so I'm gonna have to take a look at this. And I will be honest, I am a junk TV. Like if I have an addiction, I have an addiction to junk TV. So I will say that Euphoria might have been a guilty pleasure for all of a hot weekend while I was binging it. I'm curious what the rest of the panel thinks on TV shows and how they portray addiction. Do you feel like in Euphoria, it's actually interesting because I honestly was a little shocked. I didn't, I think that's the point of these TV shows. But at the same time, I wasn't shocked because working with a lot of college age people, in high school age people, I kind of see that kind of behavior happening at times. I'm curious what your thoughts are, and what do you guys think is the role of maybe social media or popular ways of people getting their resources?
I can't specifically address Euphoria. I can, having just binged Inventing Anna, and also having certainly paid attention to other media depictions of addiction. We talked about that a little bit with tobacco, that one of the things that the tobacco industry has done for decades is to purchase product placement in movies and television. It was a huge effort in the last few decades to get that to be regulated, to get billboards regulated. The issue is norming behaviors, right? So I, as an intern at the Cleveland Clinic, went and protested in front of a particularly egregious Virginia Slims billboard, and did so with a cohort of medical students from Case Western with me. I also wrote the first article in a major women's magazine, in Vogue, when I was an intern, on tobacco cessation, and it was the last of 6 articles that I wrote for them because I and my editor got fired for it. Tobacco, of course, has been a huge advertiser, the major advertiser for women's magazines for a long time. And so, of course, all of these depictions norm the behavior and give people usually a somewhat glamorized and sanitized version of what the experience is. I'll stop there. Miriam?
I've watched The Queen's Gambit on Netflix, and you can see the main protagonist, her only real caregiver, who was a steady person in her life, dies on the show from alcohol addiction. And I thought the depiction was very realistic, and then the protagonist is also using, and she's using so she can relax and so she can escape trauma. And it really opens her up to the mental capacities that she would have if she weren't constantly experiencing that trauma. And my favorite part is at the end of the series, where she finds that she doesn't need the substance anymore to access that part of her brain. And so I think that you see this criminalized substance, or this controlled substance that she's using, that in some ways could even, maybe this isn't good to say, but even be considered helpful in some ways if used appropriately. And then we see this uncontrolled substance, this alcohol, in that same series causing so much pain and dysfunction. And so it's really this upside down kind of world that we live in sometimes, but there are other great questions. So I'll stop there so we can get to the other questions.
No, and I think that's a great point, is that social media and media in general could be used in both a positive and negative, right? If it glorifies, it could maybe attract people or make them not see the risk that they might be engaging with. But if it has a more realistic view, it could actually possibly be helpful. Maybe it gets people to start realizing the reality of what things could be. And then, like Dr. Frank, like you noted, we can be engaging, right? We can go out and make changes. So like we can, like as physicians, when a physician and a physician group goes and protests, especially when we throw our white coats on, I think that usually gets people to look at us. It can make people start thinking, well, wait a minute, if the doctors and the medical professionals are going beyond just their offices, that's important. And then writing, I mean, I think that's fantastic to take that risk where you're willing to get fired over something that matters because you're not going to bow into what big money and everything else wants.
I'm gonna,
Yeah.
I just want to give one more empowering anecdote to the med students. So when I was in med school at Mercer in Macon, Georgia, I graduated in 88. And when I was a junior medical student doing my rotations at the hospital, they were still selling tobacco in the hospital gift shop. And so I put together a little petition and circulated it and got faculty and students to say, what are you doing, right? And we had just gotten the hospital to go smoke free otherwise. So two consequences of that, and I'll tell both these anecdotes really quickly. On the getting the hospital gift shop to stop selling tobacco, the head of the hospital complained to my dean, like, who's this pushy med student? And the dean completely supported me, and we got tobacco taken out of the hospital gift shop. And last anecdote, I was on my surgery rotation, and I knew I wanted to be a preventionist. I already had my MPH going into med school. And I was walking down the hall, and there was this man in a white coat smoking a cigar. And I walked up to him and politely said, "Excuse me, sir, but do you know that there's no smoking allowed anymore in the hospital?" And he said to me, "Young lady, do you know who I am?" And I said, "No, sir, I don't." He said, "Well, I'm the chief of surgery." And I paused for just a moment and I said, "Well, sir, then you should know the rules." And the only negative consequence of that was my end of rotation assessment had all sorts of positives. Erica is great and all these things. Only weakness, Erica has interests other than surgery. And that was a weakness I was willing to own.
Yeah, that's fantastic. I mean, stand up, and if you're doing the right thing, like sometimes it's standing up for the right reason when no one else is doing it, right? And that's huge. And getting that, knowing you have that support. There was a question about not so much the way that we say it, at least directly, but what they may be saying about themselves. So I think this was, and it goes on about when the diabetic potentially say the same thing about themselves. So I guess the question is a little bit along that line of, if I'm reading it right, is like, how can we engage with our patients maybe to figure out how they see themselves and maybe change the perspective that they have of themselves? And I'm not sure if you have any strategies you could share.
If I could jump in, I'll start that one. Language, I think, is critically important. I will never describe a person as an addict, because their disease does not define them. They are a person with an addiction.
Mm-hmm.
It's the same thing when patients tell me that their urine is going to be clean or dirty. I tell them, I say, I use the words positive and negative. And one of the students expressed a concern that in telling somebody they have a disease, might we be telling them that they are somehow broken? I think that was the question. And again, I said, no, people who have an illness are not broken. They have an illness, and we treat it. Again, I think because of our history, and again, this is a disease where the disease itself requires a behavior. Often that behavior starts with stupid decisions that somebody made when they were younger. But let's not judge people, right, if we haven't been in their shoes, right? There was a context in which they made that decision that we could, in retrospect, call stupid. And they behave badly because of the way that the drug prompts their brain, makes their brain so desperate to seek it. So I think I think the stigma is understandable, and the notion of thinking of it as different from other diseases is normal. But I think the disease model really can allow us to just say these are human beings who deserve all of the respect and love that any other human being deserves, we should be giving that to them in their clinic.
Mm.
You know, I think it's critically important to make somebody who comes in and asks for treatment for substance abuse, that dignity is an incredibly important part of the treatment.
Absolutely. Thank you. And then there was, you know, and there is a comment I read along that line about in general, that we need to make efforts to destigmatize the word disease rather than maybe not use the word. Because people, I think, sometimes maybe have a challenge. I think this is where it's coming from, is like where people might be embarrassed to admit they have an issue because of stigma, right? And the words that we might use around it. I think we have enough time for one or two more questions. There's one about the narrative of, you know, and the context where people enter it. And the question was wondering if the panelists think that the dichotomy exists if the opioid overdose epidemic, I'm trying to think of what this one is really asking. It says the implication is there that patients are at fault for developing their disease. And I think in a way you kind of just answered that question, in a sense that, you know, there's that concern that like people are at blame or should be at fault for what happens. And I'm curious, like, is there language that we can use to break through that barrier?
I think one lens to apply is what Magali showed in terms of the social determinants of health, and what Miriam talked about too, in terms of recognition of the ways that adverse childhood experiences, particularly, but other traumas, create these kinds of these needs for correcting our particular neurochemistries that have led to various kinds of psychological and sometimes physical pains. So I think having, like Tony was talking about, the same kinds of empathy that we have for overweight patients with diabetes, right? Part of the flip side of role modeling good behavior as a doc is recognizing that all of us, docs and med students and patients alike, are frail human beings, and providing part of what we have to do as professionals is not just showing competence, but showing caring, because without that, unless a patient believes earnestly that we earnestly care about them, our efficacy is going to be profoundly diminished.
Yeah, I would add that even if you think that a little bit of guilt or a little bit of shame is motivating, our patients come in with huge and debilitating levels of guilt and shame. A couple of things that I do specifically. One is I talk to people about recognizing recovery as heroic, and it is very difficult. I mean, you know, and I use a lot of metaphor. It's a short circuit of the brain, and I say, you know, I think all of us might reflect. Imagine if eating would kill us, and our only way of being nourished was through an IV, but we did not lose the sensation of hunger. And in fact, we gradually became more and more starved. You know, imagine spending the rest of your life never putting food in your mouth with that biological drive pushing you to eat. That's what somebody who is fighting addiction and is trying to recover is trying to do. And so again, giving them metaphors and, you know, and using the language of heroism, so that, because again, they already have way too much shame and guilt. We want to alleviate that, not rub it in.
Absolutely. Magali?
Yes, another thing I wanted to say is I think it's very important for us as physicians to advocate for a change in the narrative in the media and the newspapers or on the TV, because I remember like conversation I had with a psychiatrist just last week, and we were talking about people suffering from addiction or from other mental health issues. And he said, well, what is it, why you can see in the newspaper, well, someone suffering from schizophrenia killed some people last week, but you'll never see, well, someone suffering from diabetes killed some people. So that kind of narrative that we see in the media is also something that's very, it has very negative impact on the patients. And I think it's our role as physicians to advocate for changing this kind of narrative. And because if the public opinion sees addiction or other mental health issues differently, then that will help the patients.
Absolutely. I agree. And I think that's one of those interesting things that you can develop as a future physician, right? Is learning how to change that narrative. And that's a really great role because, when I think of it, we have 476 students still on the call, which I think will end the Q&A at this point. And we will move into the reflective statement component for the students on board. But like the great thing about it is that they're all people that can change that narrative, right? They can go out and be touch points now. So when they're on a rotation, hopefully they can take items and knowledge that they've learned from the four of you. And maybe they can even, if they see they're attending, like you said, like if they see they're attending smoking the cigar down the hallway, they can just say that one simple little thing that maybe changes the way that other attending physicians behave, or the way that us in a health profession behave, so that we can really, change the way that we, see people as a whole. So I just want to thank all of you for taking the time this morning. Thank you, Dr. Niwagaba, for bringing all of us together, and student Dr. Thomas for sharing your insights as well. For the student doctors on board, you got your email just a few moments ago that has the reflective statement. So please go in, spend 15-20 minutes doing that reflective statement. There's just a few questions in it that you have to answer. And then make sure to click the submit button. I put a reminder in there because it looks like the survey is done, but you got to click the button on the bottom so that it gets registered with, and then I'll be de-identifying the data and sharing that with our team here so that they can be aware of the impact that they've had on you in just the last couple hours. Without further ado, I want to switch the program over to Ms. Deb Heinemann. She's going to go into our careers in medicine component, and I know she's been logged in for the last few moments. So thank you all again.
Thank you as well. It was a pleasure being with you. And I think we'll go ahead and sign off now. And look forward to following up with you and your students, and of course with Dr. Niwagaba as well. Thank you all so much. Bye.
Bye-bye.
Thank you, everyone. Goodbye.
And so for those of you who don't know Ms. Deb Heinemann, you should know her. Know how you're going to find your right choice in, specialty planning. If you have questions about, your game plan in planning for residency programs and all that, you can't stop, or you can't start too early with Ms. Heinemann. She has years and years of knowledge, and you figure that she actually looks at every single student every year that graduates and works pretty much individually somehow. I don't know how she does it. I'm just honored to be able to work down the hall from her, and I see the amount of hours she puts in. But if you think of it, each class has somewhere around 280 to 300 people graduating, going into residency. Just compound that for the last 5 years. That's an immense number of people. My math is escaping me right now, but she's worked with thousands of our graduates. And so without further ado, I want to turn this over to Deb Heinemann, and she'll share with you some insights that I think will be really helpful for your professional development.
Thank you, Dr. Blasey. I really appreciate what you said. For the class of 2024, there's a couple of things I wanted to share with you. So I'm going to share my screen. Okay. As you know, you are going to be the first class where most of you, the majority of you, are going to have pass-fail for your COMLEX and USMLE exams. So it's important as we go through this process for you to identify what specialty you're interested in, but not only that, but what you can do regarding your specialty that will enhance your CV, your application, and set you apart from the other 40,000 plus applicants that'll be going through the same year you will. But first, I just wanted to give a little update about what programming Juliana, Viviani, and I have for your class as a second year through the match. So this month, you received an introduction to careers in medicine during orientation. And I remember speaking to your class about finding the right fit and doing the MSPI inventory, which will sort of give you a sense of, based on your values, based on what you like, the fields that would be most relevant for you as a physician. Hopefully you completed that. I know for year one students, they're required to complete it by the end of April. So what we're going to look at a little bit today is establishing your professional identity and a self-assessment that'll take about 10 minutes of your time and help you maybe gear yourself toward some specific specialties. I'm going to be restarting again a day in the life of a resident program. Our first one is this month. It's going to be OBGYN. Our program in March will be anesthesiology. In April will be diagnostic radiology, because those are three of the more popular specialties that we weren't able to get through last year when we did EM, FM, IM, surgery, and PM&R. In June, you're going to gain limited access to ERAS. And what that means is that you're going to be able to update your profile in ERAS, and you're going to be given access to request letters of recommendation. One of the things I'll talk about in April is that letters of recommendation from your third year clerkships are acceptable. It's a new component that was developed as a result of the merger between AOA and ACG&E. You're going to begin your third year clerkships in August, and that's when you can start requesting your letters of recommendation. In the spring of your third year, we will do photos for ERAS, and we'll have multiple days, multiple times. And we will present the entire introduction to ERAS process in April. Then your fourth year, I know we're getting far, but you will not believe how fast this will fly by. In June, you will have access to ERAS. July through October, we do interviewing skills workshops. In August, those that are interested in ophthalmology will start uploading their documents. In September, the military students will be starting to upload theirs. And right now we're looking at September 15th for the application date, but we're not sure because most of the schools and everything going on is trying to go back to pre-pandemic timelines. In December of 2023, the military match results. In January of 2024, ophthalmology and urology. And your match week is March 2023. And just so you know, match day is always the third Friday in March. So one of the things to think about is establishing your professional identity. You are going to be transitioning this year from being a student physician who is in the classroom to a student physician who is actually going to be in the hospital, rotating, participating, working with residents and attendings for the next year. So your professional identity is defined as one's professional self-concept based on attributes, beliefs, values, motives, and experiences. It forms over time with varied experiences. So as you go through, your medical school career, your identity is going to change. And you're going to change as a result of your experiences, but not only that, feedback about your talent, values, and preferences from others, basically your evaluations, your attendings. And it's more adaptable early on in one's career because you're changing much more than someone who's been a physician for 30 years. They're pretty much set in what their professional identity is. But as you go through medical school and change through medical school, residency, even possibly fellowship, your professional identity will change. So new roles, this is according to research, require new skills, behaviors, attitudes, and patterns of interactions, which have the ability to produce fundamental changes in your self-definition. So adapting to this new role will require you to navigate and redefine yourself as a student and then a future physician. It's how others see you and can either help you or hurt you in pursuing your career goals. Work values are thought to influence how an individual practices an occupation rather than the occupation an individual chooses. And that's across the board, not just in medicine. The physician values and practice scale, which is the self-assessment I was referring to, which takes about 10 to 15 minutes, will measure what is important to you as a practicing physician and what you want from your medical career. Choosing a specialty can be daunting and can be nerve-wracking and can be scary, because there are those of you who come into medical school knowing what you want, and there are those of you who may not decide until after your third year clerkships what you want. I've met with students in the beginning of their fourth year that are still torn between specialties. So it really is a very nerve-wracking experience in the sense that you're basing your whole career on, what specialty you're interested in. Values play an important role in the choices we make and in the satisfaction and quality of life we experience both at home and work. So this assessment will help you understand what's important to you in your career, your environment, activities, and how you want to practice medicine. And it only takes 10 to 15 minutes to complete. So what are the specific physician values? After you take the exam, you're going to come up with one of 6 values. The first one can be autonomy, which is basically defined as freedom, independence, and control over clinical decision-making and opportunities to work creatively. Those who rate autonomy high prefer to work independently and determine with little constraint how to treat their patients and their time. And it's a common value among physicians across the board. There is no real specific specialty that this applies to over another specialty. The second one is management. So a high score for management is defined as supervision, leadership, and administrative responsibility. And those who rate management, who come up high in management, prefer to lead, supervise, and be responsible for others. So those are the ones who seek administrative managerial experiences within a healthcare team or academic department. Could be a chief resident, could be the program director, the associate program director, but that's also not non-specialty specific. Now, the next 4 are will have specialty specific leanings. Prestige. Prestige is defined as recognition, social status, and financial compensation. Those who rate prestige high prefer to contribute significantly to or advance their specialty in the field of medicine. They want to be recognized for their accomplishments and be a top physician. And the number 1 specialty that this refers to is neurological surgery, but the other specialties that this really refers to are all surgery and most subspecialties. So if those are specialties that you're interested in, you should really score high in this assessment on prestige. Service. Service is defined for caring and contributing to the welfare of others and working with community services. These physicians rate service highly, prefer helping others simply for the sake of helping. And for this specialty, there are 2 pretty common factors. We all know family medicine, that's what it's geared to, but emergency medicine, believe it or not, and physical medicine and rehabilitation are 2 of the specialties that score very highly in this category. Lifestyle. It's a new buzzword with medical students for the last 2 or 3 years because a lot of students change specialties because after doing, let's say, OBGYN, after doing a rotation OBGYN, they suddenly realize how intense the lifestyle is. It's not a 9-to-5 lifestyle. It's a very different lifestyle. So it has become a word that a lot of students look at when they're determining their specialties. So it's basically defined as hours worked, call schedules, work demand, but having time for leisure, family, and friends. And the two specialties that score the highest with this is psychiatry and PM&R. And finally, scholarly pursuits. Those are students that want to engage in research and teaching activities. And neurosurgery, once again, is the highest in this specialty, and then surgery and all surgical specialties, such as orthopedic surgery. So this is a chart with the average number of, the average score for each of the specialties. And there's just a couple I wanted to point out. If you look at anesthesiology, it is one of the specialties that scores very high in lifestyle. If you look at family medicine, it scores very high on service. If you look at neurological surgery, it scores equally high on prestige and scholarly pursuits. Otolaryngology or ENT scores high on prestige, psychiatry on service, and urology on prestige. So when you take your self-assessment, this is another tool to help you determine what specialty, based on the environment, your lifestyle, and other qualities, would be one of the best options for you. So career planning checklist for this point on. As always, academics and your board exams are a top priority. You also should have added some co-curricular activities to your CV from your first year. Research. There are some specialties that strongly recommend research while others do not. You look into research if you're interested in continuing research, looking to gain experience, or if you're thinking of a highly competitive specialty. So all the advanced specialties, all the surgical specialties, and internal medicine are specialties that look for students with research experience. And I want to clarify something that a lot of students misunderstand. Research experience does not necessarily mean it leads to a publication. It means that you were involved with a faculty member, whether at a hospital or at a medical school, in research. Sometimes research does not result in a publication for several reasons. The PI relocates, the PI stops the research project. COVID-19 had a major effect on a lot of research projects in the last 2 years. So when you're looking at research projects, doing case reports, when you're in your third year clerkship and you have an 8-week internal medicine or surgery rotation, think about doing a case report. It adds some research experience to your CV, and it's something you will learn from. Volunteer, community service, and leadership. These experiences enhance your residency application because you gain valuable skills and leadership experience. And program directors look very highly on these experiences. Careers in medicine, exploring opportunities. As I've stated, hopefully you completed the MSPI, and then add this self-assessment onto it. It'll give you a sense of what specialties you should be interested in. Always try and attend residency and career planning programs and workshops that are being held throughout the year. I will give you an example. Last year I did a workshop and I had a resident from Morningside West. We had a number of students who were interested in doing a rotation in Morningside West, some of them even matching in Morningside West. And the resident who presented had given them all her email, and she has become an advocate for our students. This is why it's important to connect with current residents if possible. And that's something that many students know that I do. If you're interested in a specialty and you want to meet and then you want to connect to a current graduate resident, that's something I can do. I have a list of numerous contacts, as Dr. Blasey mentioned, and all of the students who are currently residents, anytime I ask for help, they are always willing to pay it forward. So those of you, especially in the advanced careers, like maybe orthopedic surgery, I've connected a lot of prospective orthopedic surgery with our residents at Jersey City, with our residents at Plainview, which is soon going to become Huntington. And they've been able to get research and work with those students and attend the lectures every week. So it's a good contact and connection, especially when you're going for those advanced specialties. Attend NYT-COM student organization specialty group activities. For example, ACOFP for family medicine. One of the categories on your residency application is what professional organizations you belong to. And I can tell you, program directors, look, are you part of ACOP when you're applying for family medicine? Are you part of EMRA and ACEP when you're applying for emergency medicine? It's on the first page of your application that they receive, and it's something they look at. While rotating, look for lectures, workshops in your specialty of interest, or to gain more knowledge about a specific specialty to see if it's something you're really interested in. Your CV. Update your CV continuously because you're going to be adding most of your experiences in your first and second year. I do believe, with the exception of maybe 3 or 4 of you, everyone in your class has had their CV reviewed by Juliana, and she will be reviewing your CVs again in the spring of your third year to make sure that it's all up to date and ready to go for your residency application. So what do you do during your third year? You think about your interests and you schedule an appointment with me to develop an individual match plan so that I can let you know based on your, well, you're not going to have scores, based on your interests, what hospitals and programs we've matched at that make sense for you and your specialty. And I just wanted to remind you again about medical specialties, how you can start searching and gathering more information. You all have access to careers in medicine. So you go to the link, choose your specialty, explore options, and pick your medical specialty. So for this one, I picked emergency medicine. And the first page is going to be an overview. It's going to give you salary. The scores aren't going to matter to you, but it'll give you the number of hours, the average number of hours worked per week. And here's something to look into. Characteristics of entering residence. And it gives you the characteristics of students that how many applied for each specialty. It has their average scores, et cetera. But it also has something else, which is important too, which is the average number of research experiences a person has for that specialty, the average number of volunteer experiences. So this is an opportunity for you that, you know, if you don't have as many experiences as the specialty is looking for, to add them to your CV before you start your third year clerkships. Now, one of the other reports that's really important for us as an osteopathic medical school is that the NRMP match program puts out a report every year called US Osteopathic, it's an match outcomes report, US Osteopathic Seniors. And it provides information on the match results specifically for osteopathic medical students. They're by state, by specialty. For example, here you see general surgery. The average COMLEX, and I'm just using these as they're easier to read. The average COMLEX score for someone who matched general surgery as a DO was 609. Unmatched was 536. The mean number of work experiences was 3.6. The mean number of volunteer experiences was 7.5. So these are statistics that are updated every year based on the prior year's match that will give you a sense of what you can do to help enhance your CV. And what's really important about this is that most osteopathic schools don't have their own affiliated hospitals. And this is something we learned through the pandemic with rotations. For example, Stony Brook students were able to rotate through Stony Brook Medical School in the first year of the pandemic, but our students, they weren't allowing away rotations. So they had a lot of online rotations. So these are additional experiences that you can add to your CV as you're going through and thinking about your specialties. So I know this is a lot of information, but what do I do with it? Well, you make a list of places where you'd like to be. You know, the third question I always ask a student with meeting them is, do you have any specific locations where you'd like to match? And if you look at the stats outside my office, you'll see that about 75% of the students match in New York State. Then what hospital and what program? Research the programs in that area. Make a list of programs and research them to see how you can make yourself more competitive for those programs. Look at the residents that are currently there. Speak with someone in that specialty. Now, who can you speak to gain knowledge and insight about a medical specialty from someone in the field? A faculty member, a faculty mentor, a PI, your own physician, maybe a current or former supervisor where you've worked or shadowed before, a preceptor, a resident or attending. Potentially anyone in your circle of family or friends can be someone that you can talk to about a specific specialty. And what kind of questions should I ask? And Careers in Medicine has a really complete list on this. And these are questions that you can ask someone when you're trying to understand if that specialty is for you. For present professional experience, what's a typical day like? What's the most challenging aspect of your job? What are the common qualities of those who are successful in your position? Ask about past professional experiences. What was your application interview process like? What would you have done differently if you could? And when you think about your first year as a resident, what activities or actions were key to your success? And then you ask, about the person's professional future and think about, how you can be successful based on what they're telling you. What are some career paths that are open for someone in your position down the road? I have a copy of my CV. Could you let me know your thoughts on it and maybe how I can prove it if I'm really interested in this field? And what advice do you have for a medical student like me who wants to pursue this field? So not only do you have your own faculty on campus, your own faculty mentors on campus, but we have connections with so many residents, and Alumni Affairs has connections with those who've already graduated their fellowship and fellowships and residencies as well, that can provide information for you to help you guide you in your choice. And as always, both Juliana and I are available to answer any questions you have. You can send an email at any time and we will definitely be available to help. And that's it for your second year Careers in Medicine presentation. Dr. Blasey?
Here we go. Excellent. So thank you so much, Deb. Is there any questions from our second year class? I mean, there were so many key points in there that are take-home messages, and I think a lot of it is just starting to ask questions and, be inquisitive and figure out who you are and what your goals and what you want to get out of life is, and start making some, connections. And I can't stress enough about being involved in your professional society. Like you said, like the question about if you're interested in family medicine, make sure that you're part of the ACOFP or the AAFP, being involved in those organizations. And, if you have a chance to go to one of those conferences, we always do, like, we can't send like financial support to send you to these conferences, but a lot of the state societies have meetings and things like that. And that always gives you opportunities as well to branch out and meet with the different people that are involved in those programs. So I know when I was a student, I was involved in the ACOFP and the state ACOFP, and that's how I got to meet so many people that eventually became my program directors and different people like that.
And a lot of those organizations also had mentor programs, so you can actually, work with a physician practicing in the field, and they can become your mentor throughout the next couple of years.
Absolutely. And you can never underestimate the power of a mentor. I know my mentor is still my mentor, Dr. Nancy Bono. She's our department chair for family medicine. I met her in 2003, and she helped me walk through pretty much every hurdle of my life since 2003. So, make those relationships. There's a question about, will Careers in Medicine PowerPoint be available after the Zoom meeting is over? How did you want to send this out to the students?
I guess I can send it out over the weekend.
Okay, sounds good. And then there was a question with our step 1, level 1 going pass fail, would you recommend taking step 2, level 2 earlier, or a research year and taking step 2, level 2 during then? Particularly if you're interested in a more competitive specialty. So the one thing I will share is if you want to do a research year between years 3 and 4, you have to take and pass your level 2 before you can do your research year. We can't let you go on basically we can't have you go out on that research hiatus until you pass that. And you can look at the student handbook, and it has a lot of the details of that component. Well, what's your thoughts, Deb, on step 2, level 2, taking it? Like right now, I think most students should be taking it in June, July, August, between third and fourth year.
I would you have the dedicated study for them in slot 1 in the fourth year. And I think that's when the student should take it. You generally want to try and have your scores by the time you apply. So let's say this year's deadline was September 28th. So you would want to take it in June and July, and you want to take that dedicated study time. It's, you know, a lot of students think first year is the most difficult, and I totally disagree. I think the fourth year is the most difficult. You're studying for board exams, you're auditioning, you know, doing audition rotations at hospitals, you're interviewing for residency. There's a lot of things going on. And if you have a dedicated time where you don't have anything else to do but study for those exams, you want to use it to the best of your ability. I can tell you right now, I have students who just took Comlex 2 or have been taking Comlex. It has an effect on how programs, you know, interview. Anesthesiology will not interview students unless you have all your scores. They want both level 1s and level 2s. And that's the same with your advanced specialties. So I think if you have the dedicated study time, and that's what it's built in for, that's when you take it, because you have nothing else to focus on at that point.
Yeah, I agree too. And I don't think there's any, I mean, there's really no benefit of getting a level 2 step 2 score early. You know, it's like you're all gonna send your applications in at the same time. So as long as your scores are in by the time you send your application in, that's fine. There's no other questions.
Okay.
So thank you so much, Ms. Heinemann.
Thank you so much, Dr. Blasey.
Thank you again for joining us this morning. Bye.